Introduce the Dean of Academic Affairs, Amy Feest. She's just going to start the event with a few remarks and welcome our panelists.
Hello. I'm not going to use the mic. I think I'm pretty loud. Can you guys hear me in the back?
Oh yeah.
Yeah. I'm not the quiet one. I want to welcome you guys here this morning for this really important conversation. Were any of you here when we had this first half of this conversation a few months ago? So for those of you who were here, I'm very excited to continue. We had a wonderful conversation sponsored by the Civic Engagement Institute on the opioid crisis, and it was such a success, and people walked out asking for more. So here we are with part 2, and I thank Professor Fierro and Cliff and Ira. Where's Ira? I know he was here 2 seconds ago. Their work in the Civic Engagement Institute to bring these kind of discussions to campus is amazing and is really allowing for some dialogues that, while maybe uncomfortable, are really important for us all to have and to understand. So I thank you all for being here today. Here comes Ira, he's standing outside. I thank you all for being here today to be part of this conversation, and I thank our panelists today for taking the time to engage us in this conversation and to enlighten us on this opioid epidemic and to allow us to express our points of view and to see ways that we can get involved with change and solutions. So thank you for being here. Please be attentive. Give them your 100% respected attention. They've all taken time out of their very busy days to be here, and I appreciate you guys giving them your full attention. And thank you again to the Civic Engagement Institute for allowing us to have these conversations, which are so important.
Thank you, Amy.
You're welcome.
Appreciate it. Well, I would also like to thank you all for being here. This is an important event, as Amy just said. I'd like to welcome you. This is a full crowd. I'm glad to see that. We had something like this a year ago when we had a discussion on the opioid crisis, and this is why we're here again. We thought we'd look at this issue from a public policy perspective today, which is why we brought in some extremely good panelists to discuss the issue of what government, combination with private activity and businesses can do about this, and what we all can do as a society about it. So our guest speakers are from right to left. This is James Schlatter. Many of you may know him. He teaches English here. He's been here for 9 years. He makes drug abuse and the drug war in particular a very important part of his Comp 2 classes. So if you ever want to take Comp 2, good guy to take it with. Also, we have Rennie Fulco. She teaches public policy at Trinity College. She's actually professor and director of the public policy and law program there. And she especially focuses on the intersection of law, politics, and public policy. And she teaches a course on federalism and public policy there at Trinity today. She's also presented her work at professional conferences in the United States and abroad, and has served as a political commentator for local and national media. So she has a lot of experience with this issue and how we could possibly tackle it. Also, Mayor Ellen Zoppo-Sassu has been here before. She spoke to Tunxis students, I think it was a year ago or so. It was in the spring of 2018, and she was kind enough to come back again and speak to you about this issue and what the city of Bristol is doing about it. And with her is Chief Brian Gould, who I just met, but he was kind enough to be here as well to talk about some of the law enforcement issues that surround the opioid epidemic. Just a couple of things before we get started. This opioid crisis obviously has impacted all of us in one way or another, directly or indirectly. The Center for Disease Control has called it the worst drug overdose problem in American history. And I think with good reason. And you'll see a map later on in the presentation that just shows you how widespread and how far-reaching the epidemic has become. So Tunxis is a small school. The Civic Engagement Institute is a small campus organization. We try to do our part and have these activities and get all of you involved and educated on it. So we can do our part in bringing attention to the issue, but what we need, I think, nationally and locally is a more sound policy to address the issue of opioid abuse. And so that is what we're doing today. So we'll begin with Professor Schlatter. He's going to have a few words and then open up the conversation in the form of questions to our other panelists. Thank you.
All right, let me try this microphone here. Let me just first ask a quick question of everyone. How many of you, yourself, a family member, a friend, somebody you know who has, know somebody who's addicted to an opiate, heroin, something like that? Let's see a show of hands. Everybody who knows somebody. It's probably about 75% of you. So I wanted to speak just a little bit about, the numbers are alarming as far as the opiate crisis. I wanted to speak just a little bit about the collateral damage. Not just people who get hooked on opiates, heroin, fentanyl, things like OxyContin, but all the things that are associated with that. So for those of you who are in my classes, or just maybe you know, what do you think some of the things are, other than the addicts themselves, what other things are affected by the drug or drug policy? What else do you think is surrounding that, or what else is happening with that? Anybody have an idea? Yes, Spencer.
Prisons being filled up with addicts, not active criminals.
Prisons, absolutely. So not just people who are selling, but addicts, users. Let me look at this. I think I wrote this down. Every 25 seconds, somebody in this country is arrested for drug possession. Disproportionately African American and Latino. So we're talking about, I think the statistics are a fifth of all people in jail are in drug-related offenses, costing this country billions of dollars a year. So yes, overcrowded jails. What else? Yes?
Gangs.
What about gangs, Chike?
There's just different gangs that get.
Hey. There are different gangs that get people involved all over the country and all over the world. So that's one reason.
Okay, so turf wars, violence, all kinds of things like that. People dying, the drug war. So not just overdosing, but innocent bystanders as well. Something else? Yes.
Family dynamics.
Family dynamics in what way?
Well, of the addict, there's a breakdown in the relationships in the family, for whatever reason.
Absolutely. Families devastated, right? Families, friendships, everything with addiction. Yes, totally agree. Somebody else? Yes, Robin.
Well, we have a whole generation of children being born addicted and their parents not being able to care for them, so they're sort of overcrowding the foster care system.
Absolutely, yes. The infrastructure around this is taxed. Yes, absolutely. Somebody else? Other things that are affected? Spread of disease, talking about people shooting up in secret, dirty needles, people selling their bodies to feed their addiction, also spreading disease. The secret nature of the drug war, people go out and buy drugs in the streets, they don't know what they're buying. An overdose comes from people thinking they're shooting heroin, when in fact they're shooting much more fentanyl and they overdose. Just a few more things I want to mention before I turn it over to our panelists. So this is an interesting statistic. Americans are 5% of the world's population. Guess what percent of the opiates are consumed by Americans? Anybody want to take a stab? Yes. 80%. Americans take 80% of the world's opiates, 5% of the population. One last statistic before I turn over to our panelists. According to the University of Washington, the study put out by the University of Washington, Americans are the most addicted population in the world. This is not including alcohol, but all drugs. Drug addiction, 3%. That's around 10 to 12 million people addicted to drugs. So it's a colossal problem in our society. Not just the addicts, which of course is tragic, but all the collateral damage as well. And so I want to turn to our panelists next and get their viewpoint first locally, what we can do in Bristol and local communities. Turn it over to the mayor. If I just want to ask you, what's the way forward given all these problems? What can we do locally to to sort of mitigate these problems, and Officer Gould as well.
Thank you. So we're happy to be here because this has actually been a major policy initiative since I was elected in November of 2017. And as a little bit of background, we're going to do this in two parts because there's clearly two public policy aspects that affect communities. One is the illegal nature of heroin and everything that's happening on the streets, and the police department response to that, as well as the general government response, which Chief Gould will address. And then I'll come back and talk about our public policy response. But the reason that this came to kind of a large point in time response was during the election of 2017, when I was actually a candidate for mayor. I was still employed as the Director of Government Affairs and Regulatory Issues for the Connecticut Pharmacists Association. And in that role, we were dealing with our pharmacists, who are members of our association, dealing with the opioid issue, with false scripts, with doctor shopping, with all of these issues, and seeing an incredible flow of narcotic and controlled substance abuse issues within the pharmacy. So we looked at that in terms of a public policy response in relation to the pharmacist industry. We were also very happy to partner with then Governor Malloy on his really groundbreaking 2013 legislative package, which started to address some of these issues. And Connecticut was actually a role model in the country for some of these issues. But to fast forward to 2017, things started to kind of really accelerate in terms of what was happening in the communities. So in my official role at the Connecticut Pharmacists Association, I had access to the prescription drug monitoring program, where all doctors are supposed to upload and load the prescriptions for patients. It's kind of the precursor to what we're hoping to be the e-records and sharing of medical information amongst providers, which would hopefully provide a more healthy outlook for patients. A little known fact is a lot of medical professionals don't communicate. So for example, if you have even something as a simple eye problem or glaucoma and you're taking eye drops, those eye drops could actually interact with something else you're taking, your cardiac medication, something else. The fact that all medical professionals should and will be soon communicating is a huge advancement in how we manage our healthcare. But when I looked at Bristol's stats within the prescription drug monitoring program, I found that for calendar year 2016, which was the last complete data set that we had at that point, there were over 150,000 prescriptions for controlled substances written for Bristol patients. We don't have a pain clinic in Bristol, we have a hospital, but there really was no reason for that many to be that high. And when I delved deeper, I found that out of those numbers, almost between 38 and 53,000 of those could be traced directly to narcotics and controlled substances. So we knew we had an issue right here in Bristol. Trying to track that really brought me to the point of realizing that there's two direct paths for policy issues. One is enforcement with the flow of illegal drugs into our community, affecting the dynamics on so many levels, but then there's just the prescription drug pain management aspect, which can also lead to people becoming addicted. So we're going to spend a little bit of time on both of those, but I think the more important one, in terms of the one that gets the most attention, media attention, as well as I think some of the perception issue, is that in dealing with heroin, fentanyl, and everything else that's in our communities. And for that, I'm going to yield the microphone so you can hear from Chief Gould, who's been a great partner with us in terms of how we are attacking this in Bristol.
Hi, good morning. Can you hear me? There we go. Good morning. First, I want to say thank you for inviting me here today. I appreciate being here. I certainly will tell you that I am no expert in this. All I can tell you is that I've been in law enforcement. I've been a member of the Bristol Police Department for 25 years now, and I'm here based on my experience with the situation going on. So I certainly will do my best to answer any questions you have, but I do think it's so important to have these forums. A lot of people have asked me, what do you think can be done to get out of this crisis? I wish I had that magic answer for you. I don't. I do believe that the people that are going to solve the crisis are all of you. I think that we're just going to be the vehicle, the people that are able to give you information, and it's just been my experience that the more knowledge that's out there, the more power that's out there, and it will be you all and you educating others that is going to take us out of this tailspin. because as was mentioned earlier, there's no doubt this is a crisis and it's getting worse. I was listening to your points, your statements, and every one of them are accurate. It's taxing everybody and everyone, and it's a big deal. Law enforcement, so I'll talk about what Bristol's doing. And then I'll talk about a little bit what the Connecticut Chiefs of Police Association is doing as well. So we've had a philosophy change in Bristol, and I would say in law enforcement in general in the state of Connecticut, but I'm going to focus on Bristol for a moment. Years ago, it was about going out and making drug arrests, and that's what the job was when your narcotics detectives and your narcotics squads were out there. You go out and you make arrests. We've shifted on that change. We don't see this. I agree about these are not criminals. For the most part, we do have criminals out there, so I don't want to mislead anybody. But this is affecting people. It's an illness, and we want to handle that, and we want to handle it appropriately. So in Bristol, we're handling this a few different ways. So we naturally have laws in place, and we are obligated to enforce those laws. So we do have a dedicated narcotics team that's local to Bristol, and our narcotics team is looking at going after the people that are providing these drugs to our community. They're killing you, me, my family, your families, and they're profiting off it. Those are the people that we're interested in right away at the moment. We're hitting it at a federal level too. I have 2 officers from Bristol that are assigned to the DEA task force, and they're up on large-scale investigations, doing wiretaps and such, because we're really trying to get those people that are profiting off of killing all of us. And it is killing us. Heroin's always been around. The heroin's nothing new. I started in 1994 in Bristol, and we've always had heroin in Bristol, I can tell you that. What's new is the fentanyl, and the fentanyl is killing people. Fentanyl, if you don't know about it, I'm pretty sure that most of you, if you've been in the classes, most people are, can I ask you this, by a show of hands, who's heard of fentanyl? See, it's interesting, right? Because if I had asked that a few years back, no hands would go up. And if they did, it was a very minor. Who's heard of carfentanil? So there's 2 right now. So you're going to carfentanil, in a little while longer, all your hands are going to be going up. And that's scary. And I'll tell you why. So fentanyl is 80 to 100 times more potent than heroin on itself. And what drug dealers will do is they're looking to profit off you. So they're using that to cut their heroin. So a typical bag of heroin is not filled with heroin. It's going to have a portion of heroin, but it's going to have a filler in there. And many different people use fillers like baby powder and other stuff. Well, they've come across the fentanyl, and fentanyl makes it potent because they want you to come back to it. You got to have a good product to come back. So they're putting fentanyl in there. The problem is you can't handle the fentanyl. So we have people overdosing, and they're dying from the fentanyl. That's what's killing when we're getting back our tox reports, it's the fentanyl that's killing our community. You can imagine somebody thinking that they're going to have a bag of heroin, and they end up hitting up on something that's 100 times stronger. You're in an instant overdose and fighting for your life. Carfentanil. Carfentanil is coming up from the West Coast, and it's making its way. We've already had some in Connecticut. Carfentanil is anywhere to 1,000 times more potent than fentanyl. It's basically an elephant tranquilizer is what it is. You're not going to survive that. Just by touching it and getting it on your finger and maybe swiping your mouth or something like that, you've just been exposed to it, and you're going to be overdosed just like that, just by having it on your hands. So, you've heard of this, we're all swapping money and stuff like that. It's going to be a problem. So we need to understand what's in the drugs, and we got to pay attention to that stuff. So, and they're using it not in just the heroines now too. It's we're seeing people pressing it into pills, and so when you think you're getting an oxy or a bike, it's coming filled with fentanyl, and carfentanil is on its way. So we need to be educated about that. how are we doing that? So as I mentioned, from the law enforcement side, we are focusing on the people who are dealing this stuff to our community and killing them. We're also aware of the illness. So we started, I think we're about 2 years into now, at all our officers carrying Narcan. And you know, that was controversial when it first started, and it still is in some parts of the United States. There's some departments that refuse to carry Narcan. They just don't believe that they should be in that business of going out there and putting Narcan out there. And it's certainly right. You're talking money, right? I have the budget added to my budget, and but we believe that we're there to save lives. And you know, we can go out there and someone's having an overdose on an opiate. Just by having some Narcan, we can instantly reverse that effect. And it's just a simple nasal type situation. It's like a nasal mist, and it instantly pulls these people right out of that. And we are saving numerous lives with our Narcan program. From that point on, so just going back and giving you a little history, I mentioned before that in the past it was about arrests and getting numbers and statistics. So there might have been, you know, 15, 20 years ago where you might have gone to an overdose, and when you processed the scene, there was some drugs or there was some paraphernalia around, and oftentimes it was followed up by some type of arrest. You know, we're no longer doing stuff like that. What we'll do is if we go to an overdose and we end up giving somebody Narcan and they end up going to the hospital, that's the extent of us right there. We're not out there to arrest that person, to put them through the process, to then possibly getting into an overcrowding situation. We're way more interested in diverting them. So we're looking at all types of diversion programs. We also have, we put a drug box in at the front lobby of our police department. You're seeing more and more police departments doing that now. One of the things that I've seen going through my career was a lot of our youth are becoming addicted to this stuff because they're finding it in their medicine cabinets, you know, maybe at their parents' house or grandparents' house. Nobody knows what to do with their medication. Many years ago, people used to flush it down the toilet, and then we've all gotten away from that stuff, right? Because it affects our water system. We don't want to do that. So where does it go? So we not only participate, we have throughout the year, we do drug take-backs in different parts of our community, but 24 hours a day, 7 days a week, you can come to the Bristol Police Department. It's an anonymous situation, and you get to dispose your drugs. Now, we don't take in the heroin and stuff or sharps or anything like that. And I'll be honest with you, I'm exploring programs like that too, to come in and get rid of sharps. It's just something that I need to facilitate, try to figure out how we get rid of the waste. But as far as when it comes to medications, come in 24 hours a day, 7 days a week to get rid of that medication so it doesn't end up in our youth hands. We're also hitting it from an educational standpoint, right? So our platform is really attacking it from all different angles. So again, we have the criminal side, we have the medical side, and we're also educating. So the state of Connecticut Police Chiefs Association has come up with a program called the Opiate Talk. And what we found was that we used to have programs like DARE for the 5th graders, and we had other programs in the high schools. Really kind of start to see that target age group might be around the 8th grade level, those going into the high school. A lot of things we're hearing about is people becoming addicted when they got into high school because there was some peer pressure or something like that, where a fellow student handed them something, they didn't know what they were taking, and there goes on the addiction, or worse yet, there was an overdose. So we're trying to hit the 8th grade. And what we've done is, I've gone before. Last year, I hit all the 8th grade classes in the city of Bristol. Everybody going in. We have 3 high schools in Bristol. We have 1 private and 2 public. And we had everybody going into that freshman year and did a presentation for them. And it was to give them some of the stuff that I'm talking about now, to educate them. And a lot of what I've seen too is parents don't even realize. They don't realize what their kids are being prescribed. You go to the doctor, and your doctor has good intentions too, and they're prescribing you a narcotic. typically a parent isn't going to understand what that is, and if my doctor's giving it to me, if it's kid or to my kid, it's got to be okay. There needs to be a lot more education on that. There's a lot more things you can be doing before you need to have an opiate in your system. You can rehabilitate, you can use other medications. So there's just a lot more stuff you can do. So we're hitting it from all different levels there, and if you have any questions or comments, that's pretty much how we're trying to attack it from the law enforcement side of Bristol. Thank you.
From the public policy side, what we decided to do is think global but act local. We're seeing the national numbers, we're seeing what's happening in the state, but our responsibility as the government running the city of Bristol is responsibility to the people who live and work there, and to redefine the conversation. We found that the first way we could do that is to bring everyone together, and we had two challenges. Who needed to be in the room, and what was our data? And to this day, almost a year after the task force formed, we are still struggling with data management and data collection. And think about the different entry points of trying to figure out what our actual data is. In 2016, the Chief Medical Examiner's Office, who was the leader in terms of data for overdose deaths, reported that Bristol had 35 overdose deaths for that calendar year, and we were fourth behind Hartford, Bridgeport, and New Haven. We don't have a lot in common with Hartford, Bridgeport, and New Haven, and that's why that statistic concerned us. Getting back into what's behind that data, we looked at police data, so we could go in and we could look at arrests, but that wasn't a true picture either, based on how officers can load their data. Maybe there wasn't an arrest, maybe somebody refused medical assistance, so there wasn't a true look there. We then went to Bristol Hospital and their emergency department to see what they were tracking. At that point, they weren't really isolating and identifying overdose. They were more on the treatment side, so that was a dead end. Then I went to our emergency medical services ambulance reports and said, okay, well, tell me who you're picking up. Now, they had a very interesting map, which showed me where they were picking up based on 14 different codes that could be related to overdose symptoms. Now, part of the problem is how you enter data. So he probably has 6 or 7 codes. Ambulance has 4 or 5 codes within heroin, and then they have a whole bunch of other codes. So we don't really have a clear picture. And then there's the anecdotal. There's the heartbreaking stories of parents going upstairs and finding their child dead. There's buying drugs in another community, overdosing in your car. But if your address is Bristol, you're loaded on our data sheet at the Chief Medical Examiner's Office. All of that's anecdotal because there were no interventions. So that's something that we're still dealing with. One set of data, though, that was very interesting to me was that the majority of our ambulance calls centered in our downtown and our highly dense neighborhoods where we have multiple different levels of housing. We have apartments, we have regular homes, we have businesses. That's where the calls are. They are not spread out into our neighborhoods, affluent or otherwise. So to me, that said that there's a dealing issue, there's kind of a congregate issue of where people are getting and where they're shooting up from that side. But the other side that concerned me was the fact that our prescription drug use, whether it's a grandmother who has knee surgery or someone being treated for arthritis, there are a ton of pain prescription drugs being used by our community, and it's leading to addiction. So we put together a task force and asked everybody to come to the room so that we could have a conversation. And the beauty of that task force are the people that are involved that sit around the table could range from Chief Gould, and one meeting sitting next to him was a recovering heroin addict. And next to her was a parent who had lost a child. And next to her was the health director of the Bristol-Burlington Health District. And next to her was our youth services director. It's a mixed group of municipal, private partnership services that we're trying to get a handle on this. And we're not there yet. But what we've done is tried to use the task force as the glue to bring together all of these resources. And the city's role, I've always felt, is that of a social safety net. So we have use of city resources already. The police are dispensing Narcan, they're responding to calls. Fire department is responding to calls for forced entry when they need to get into a place to respond. Our hospital is seeing an influx at their emergency department. Our social services departments are working with grandparents who are raising children, the foster care system, disruptive behavior at schools, need for mental health counseling, group counseling for children who are in households that can't manage themselves due to drug use or addiction. Then you go to the state stage with jail, with DCF, with all the other issues that have already been mentioned. There's also the job workforce issue where we have an abundance of very high-paying jobs in our manufacturing circles within the city of Bristol. They can't find people to work in those jobs because people can't pass the drug test. So now we're affecting the local economy in terms of production and activity. And most importantly to me, something that I've been involved in for a long time is landlords. When you have absentee landlords, you have activity happening in multi-unit housing that is not good for a community. So good activity is going to push out bad activity, and our whole goal has been a code enforcement activity targeted at these landlords who have no interest in their properties except in collecting the rent. So the route we're taking, in addition to the task force, and we've created 2 brochures, which I'm going to leave with anybody who might be interested, because there's 2 different themes. The first one is called Bristol's Opioid Community Crisis and What We Can Do Now. And in it is all kinds of resources and definitions and things to do. The other one is a particularly different cover, and it says, "You have survived an opioid overdose." These brochures are being placed in the med bags for all of our emergency responders within the city of Bristol. So as they're responding to a house, to an apartment, anywhere, as they're leaving and hopefully transporting someone that they've revived, they're leaving this on the kitchen table. So when that family returns, they have a starting point to go from where they just came from. So police, fire, and EMS will be having those in their bags. Intermittently, they've had the various drafts that we've had. It's just been finalized, and that's starting this week. So that's the first piece. These brochures are everywhere. So anybody who may not want to talk about it, because we're still dealing with a very large community stigma. Not my kid, not my family, just a phase, just something happening. If they're going to get through this, nobody wants to talk about it. These brochures are at the library, they're at the grocery stores, they're all different places where if you really need to, you can pick one up and not be accountable to anybody else and hopefully get the resources you need. So destigmatizing the issue is a big piece of it. Getting people into recovery is another major issue. Years ago, when Bristol had a methadone clinic located on Route 6, it was a huge outcry, not in our neighborhood, not in our backyard. But right now, that methadone clinic on Route 6 is servicing over 600 people. And that methadone dose that they take every day, usually in the morning before they go to their jobs, again, stigma versus non-stigma, is the only thing that's keeping 600 plus people in our community in recovery. There's just not a lot of recovery paths. So we applied for a grant as a brand new task force last summer, and we were awarded $150,000 from the Department of Public Health to place recovery coaches in our community, because we know that there are people poised to get into recovery, stay in recovery, and get out of this cycle. And that's the approach that we're taking in order to help the most vulnerable people in our population. Therapy and treatment, decreasing the availability of prescription drugs from your doctor, from the street, or wherever you're getting it, is the first priority. And increasing access to treatment and having beds available wherever they need to be when people are ready to make that leap is the most critical policy decision that's facing us. The resource guide is one of them. Educating the medical community about the prescription drug monitoring program and that it's not an optional exercise is critical as well. In addition to that, we've reached out to all of our gas stations and convenience stores and let them know that the provocative displays involving vaping and all of those other pieces are not to be on their front counters. And if they are, and if we have sting operations where we're sending kids in and they are selling to underage kids, that we've put them on warning that we're coming after them. We're also educating parents. So, and it was an education for me as well. We're confiscating materials so that when you say to a parent, do you know what this is? And they say, oh, it's a thumb drive. We say, no, it's part of a vaping equipment. This is what you're finding under your kid's bed. This is not good. This is what they use to put in it. All different flavors. This one's banana smash. You know, what is this? Oh, it's something they use for their computer. No, it's not. It's a vaping tool. So parents have to be our partners as well and not assume that the things that they're finding in their kids' room are part of something that they don't want to know about. Legislation, we're following it judiciously. Unfortunately, sometimes democracy, small d, is very messy. Over 4,000 bills are introduced at the State House in Hartford every year, and only 400 usually pass. What a colossal waste of our time when we're looking at a crisis like this to have all of these other pieces of legislation clogging up the arteries of democracy. We're trying to pinpoint in on those bills that are going to deliver services to communities so that we can continue this. And the biggest issue is, where are the treatment beds? That's the biggest issue. The Narcan training, we do those in our community to make sure that no parent walks upstairs like several of our contemporaries have to find the child that's no longer breathing. The more you can do to be advocates for the people in your family and not treat them like they're addicts, but that they have a disease that needs treatment, the longer we're going to go toward finding a piece that we can solve together. And the Recovery Coaches Grant will be something that we carry for 2 years, and hopefully, again, the role of government to be the glue that brings all these pieces together and start having the conversation. I've already seen some positive aspects with people who were afraid to talk about it. The first 6 months, we had a lot of people come and they just sat there, and I didn't know who they were. They would introduce themselves, but there was no accompanying credentials or who they were or what they were representing. And we found out after the fact they were parents. They were parents who felt helpless. They were parents who were either at the beginning, middle, or unfortunately the end of dealing with this issue. And they wanted to see what their tax dollars were going for. And at the end of the day, that's what it's about. Using those tax dollars to design a safety net to protect those that live in your community. But again, it's part of a think global, act local. And the more that all of the communities do this together, the better off it's going to be, because unfortunately, the opioid crisis has no borders. If you're not being serviced in Bristol, you're going to go to the next town over, and that communication piece is big on our agenda as well. Thank you.
Oops. Okay. Good morning. Everybody can hear? Good. It's a pleasure to be here. Although it is not a pleasure to talk about the topic, it is a pleasure to be among such an interested group of people to talk about something that is so important. And I was asked, I believe, to comment more on the national aspect and the relationship between national policy and local policy. So I'm going to give a little bit of background, and then I'm going to talk about what kind of problem this really is. And I must say, listening to the two previous speakers, it seems to me that Bristol is a model of what we should be doing in America. And I'm going to try to talk about how important it is for there to be federal and state support for the kinds of programs that you described, because it's like all of the elements that you need in order to be successful, but there has to be support and there have to be resources. And people have to pay attention. So we'll talk about how we can perhaps do that better. And I'd like to begin by saying that in the public policy world that I live in, the opioid crisis, the drug crisis in general in this country, is what we call a wicked problem. It's new terminology, but it's so perfect to describe the particular problem we are facing. And when we talk about a wicked problem, we are talking about a problem that is big, that's pervasive, that seems to evade solutions, but that requires an enormous amount of cooperation and collaboration in order to solve it. And so I would begin by arguing that we can't solve this wicked problem of drug overdoses, the opioid crisis, drug addiction in general, until we know what the problem really is. And I think that all of the previous speakers have alluded to the transformation of the way we understand the drug problem. In the 1980s and the 1990s, this problem of drugs was basically a crime control problem. We looked at it only from the perspective of crime, and the way drug issues were handled in general focused primarily on the supply side. okay? And that's often part of a crime control approach. And I will just say from the beginning, there is no reason not to have crime control. There is no reason not to focus on the supply of drugs coming in. We need to do that. The problem in the 1980s and 90s, when there was a crack epidemic, is that we didn't focus enough on the demand side. And the demand side we can define as harm reduction. That's one way of talking about it in public policy, that what we are trying to do is obviously we want to get the bad guys. We want to get people who are bringing drugs in, whether it be, pharmacists who are filling phony prescriptions, or it's people who are bringing drugs in and selling them. You need to deal with that. But you also need to deal with the issue of reducing harm to the people who end up using the drugs, and in this case, overdosing and dying. So the first step we have to take, in my view, is to redefine the problem and to say there is both a supply side and a demand side. And I think we have done that today, and I think if you listen carefully to the previous speakers, and especially to, actually both speakers, the chief and the mayor, laid out the various programs that they have. And some of them deal with crime and crime control and getting at the supply and limiting it and putting those people in jail, but also very much on the harm reduction side. What do we do with the people who are dying? And I think it is important to note that one of the problems also in the 1980s and 90s that we need to understand is that the crack epidemic was regarded primarily as what? A problem of the inner cities, primarily a problem that involved minorities. And, without going into too much detail, I would simply say that that limited the options that were available. In other words, if you see this as a problem that's isolated to certain kinds of communities, and maybe there are gangs in those communities, and maybe people sell drugs in those communities, and those are the only communities that you think have a problem, then you may well see it as just a crime control problem. Now, there were people in the 80s and 90s who were arguing in a very different way. And they were saying, no, we also have to focus on the people who use the drugs. We have to deal with the addiction, because that's a public health problem. And so one of the other changes that has occurred, it seems to me, over the past decade or so, is that we are now much more focused on the public health aspects of this. Not just isolated individuals, but that this is really a crisis that could affect anybody. And I think that that's what was spoken about already. And so we want them to think about, number one, what's brought about that change? And if we now believe that the public health dimension, this harm reduction dimension, is as important as the crime control dimension, how do we facilitate policy? How do we get laws passed that will make it possible to attack that as well? Because we already have resources. We probably don't have enough, but we have a lot of resources directed at crime control, because that's been the focus for so long. And so now we have to say, how do we get at this other side of it and have these two sides of the problem and the solutions working together, not in isolation? And again, I think we have a good example sitting right next to us here, and it's actually, for me, very good to hear that. So at this point, I would like everybody just to look at the map, because I think it illustrates some important points that we need to take into account. And if what we are looking at is the concentration of deaths from opioids, and if you look between 1999 and 2003, and we look at prescription opioids, heroin, and fentanyl and synthetic opioids, what do you people see when you look at that first map? Not that many deaths for the center map and the map on the right, and even in terms of prescription opioids, right? Very concentrated where those deaths are taking place. right? And if you notice, going all the way back to 2003, one of the hotspots here was the Kentucky-West Virginia border, which remains one of the hottest spots for this in the country, and we could talk about why that's true. And then if you look down to the second map, 2012 to 2016, this was the most recent data I could come up with, and have a nice map for you so you could visualize it. And so what do you see in terms of prescription opioids in this 2012 to 2016 period? It's spread all over the country, right? So we're no longer talking only about a small crisis. Now it's become a crisis that we can all understand. We look at heroin and compare it to the map above. Again, what do you see? These amazing hotspots of heroin deaths. And then you move to fentanyl and synthetic opioids, and you see the same thing. That there are hotspots, and look where they are, right? They're in all parts of the country. And from a public policy perspective, that ought to make lawmakers at the national level want to do something about it. And so what I will turn to briefly now, because I was asked the question, it was a good question, whether or not local, state, and federal agencies have done enough to combat this problem. And then I think we can open it up and turn it over. I don't want to talk too much because I could talk forever on this. And I actually teach a course where this is a centerpiece. So I think all of us at this table could talk, till 3 in the afternoon about this if you asked us to. So I would just like to answer that question briefly and give one possible solution that has come up. My sense is that the local level is facing the brunt of this particular crisis. It's always true with drugs, right? It's always at the local level. You may watch television and see the feds come in and do a bust and all of that. But by and large, it's our local neighbors who are either have political office, are working with nonprofit organizations that help, or are law enforcement. Those are the people who bear the burden of this epidemic. It's at the local level. There is some burden at the state level to provide funding, I think, and to try to figure out what we can do about it. But it's also the case that the drug problem is a national problem, and that's why I'm showing you the maps. This is not a problem like, what are we going to do about the foundations in the houses in Connecticut that we learned were shaky foundations and should never have been used to build houses. That's pretty much a state and local issue, even though you might request funding from the federal government. If you look at that map, right, if you look at each of those maps, you can understand this is a federal problem. So you would think, right, that members of Congress would be willing and eager to take this on. And unfortunately, they have not done so. There's a lot of hand-wringing, there's a lot of talk. There are certainly members of Congress who feel very strongly about this issue and would like to do something. But one of the things, I just want to give you a couple of reasons why the federal government has not done enough. And the first is one that I think affects all of our politics today, and that's political polarization. That for some, the drug problem is still viewed through a very partisan lens. And there are some who view it as a problem that requires crime control and crime control alone, and there are others who believe that it's much more a harm reduction problem, and there are some in the middle who think you need both. And I think the problem is, in the current environment, it is extremely hard to get people to disagree. Even though if you were to ask members of Congress, if you had them on truth serum, they would tell you, yes, this is a huge problem and we can solve it. But for political reasons, they can't. I should point out that early in his presidency, that's the word I'm looking for, Donald Trump actually wanted to do something about this and even raised the question of how best to do it. He put a commission together. The commission has come up with some suggestions and solutions, but neither the administration nor Congress has acted fully on those very good recommendations, and you may know something about this as well, that were put forward.
They have all those kind of campaign contributions.
And that's the second thing I'm going to talk about. The other problem, which you may not be as aware of, is the role of big pharma, of the big pharmaceutical companies who give large campaign donations to both Democrats and Republicans. In fact, it's extraordinary how much money they give. And as a result of giving so much money, they don't come under scrutiny. And it's only this week that we got the big pharma, last week and this week, got these people in, like Purdue Pharmacy, responsible for OxyContin, right, for putting that drug on the market. And now we're learning, not telling the truth about the addictive properties of the drug. And again, I could go on and on. Anybody's interested, you'll get my email. I'll send you stuff if you're interested, okay? But what I want to say is that's the other part of what makes politicians not act in the way they should, is because they get support from big pharma. And it's not unlike what happened with the tobacco industry, that for years they didn't tell the truth about the addictive properties of tobacco, and then we found out later they actually did know. And this is particularly pernicious because we now know for a fact that Purdue suppressed information and did not let doctors know the degree to which these synthetic opioids, the power that they had and the addictive properties they had. In fact, they advertised them as being less addictive than other kinds of narcotics that you might use in a medical setting. Okay, and we could talk about that. So I'm going to give you just a thought to throw out there. The last 2-3 weeks we've had lots of talk about a national emergency. There are people who work on this issue of the drug overdose epidemic, drug addiction in general, including a very prominent moral theorist and medical ethicist named Larry Gostin, who is at Georgetown University Law Center, and he thinks about the intersection of law and policy and morality. And this is his recommendation. He thinks that we should have, and there are others who agree with him, a national emergency for the opioid epidemic. And this is what he says: a declaration of a national emergency authorizes public health powers, mobilizes resources, and facilitates innovative strategies to curb a rapidly escalating public health crisis. So Gostin and others want to reframe this policy problem not only in terms of harm reduction, but they want to have us come out and say, as a nation, we actually have a crisis, we have an epidemic. If this were a flu epidemic, right, that was killing the number of people who are being killed by this epidemic, the opioid epidemic, we would have a national emergency. That's a common way of dealing with it in mental health, or rather in public health situations. Mental health would be for, some people think we should do that for guns, and that's another parallel. But for public health situations, and so this is just one option that is open, and there are many people now who feel that the only way you will get immediate action and the collaboration you need between federal, state, and local authorities is to have an actual national emergency so that people can get together in precisely the kinds of groups that you were describing, where you put all the stakeholders at the table, you develop a plan, and you put it into action. Thank you.
Well, before we go to your questions and comments, I just want to thank all of you for brilliant and very thought-provoking, educational way of bringing the subject out to you. How many of you learned a lot of stuff from what was said? Both the local and national levels, just incredible. So thank you very much to the panelists for the information. All right, what we want to do now is open it up to questions or comments that you might have. I don't know, Cliff, are you going around the room? I can cover this part, and Ira as well. So anybody with a question or a comment?
Alright, so my only issue is with the Narcan. Why, like, my issue is you're not arresting them, okay? They're just getting Narcan, going to the hospital. If they're on state insurance, they don't have to pay for the hospital visit. So they're choosing to do this drug that could possibly kill them. They get revived, which is spending our money, and then also spending our money if they're on state insurance to go to the hospital. So why are we gonna let these, they are criminals, whether some people won't look at them as criminals or not, they're using illegal drugs. So why are we gonna let these people that are breaking the law not get arrested? Yes, it would take up room in the prisons and jails and whatever, but why are we gonna let them break the law and do something like that? I mean, if they can't be sent to jail or prison, then they should be sent to recovery on court order. Like, why are we not gonna, that's another way that we need to push for these people to get the help, and rather than spending your money on Narcan, it should be spent on recovery places. Because the people that are doing these drugs, they know what the things that can happen, they can die, they can overdose, all that. So like, why are we gonna revive these people that are purposely doing it? It's like me going to a building and jumping off. Like, I know what's gonna happen. So, I don't know. I just think that's an issue that needs to be fixed. So.
Who wants to address that? Maybe the addictive nature of it might stand in the way of having it be a completely personal decision.
Sure, it's a great question, and I'm sure there's other people that can chime in too. I can tell you from our point of view is that when a person is overdosed and when we're issuing the Narcan, they're on death's doorstep. And we're looking to break that cycle. That's a medical emergency at that moment, and our first priority is to get them help. Now, a lot of these diversionary programs, once they go in to get the help, we partner with like Bristol Hospital, there's other hospitals and stuff that once they're in there, they're able to come back in the back end and help them get into diversionary programs. I do want to say this, that when it comes to an opiate overdose, especially a death, an investigation does happen. The investigation, though, is figuring out where that came from. So that's a big step that Connecticut has taken. So when we go into an opiate death, and it looks like it was a death from an opiate, we partner with federal and state agencies, and we begin an immediate investigation, tracking cell phones, computers, what have you, and we try to track where that substance came from. And those people, when they're found, are actually being charged with manslaughter charges. So there is a connection that's being drawn. But, it's a multifaceted approach, and it's really about breaking the cycle at that point. And I will tell you that I certainly appreciate and value your views. They're great. My experience in it is a lot of these people don't know what they stepped into when they overdosed. I agree with you that a lot of people understand jumping off a bridge, but some people they really don't. And I think it's important for us to be out there and saving lives.
I was going to ask this question later, but this is central to the topic. The statistic you gave earlier just struck me that fentanyl is 100 times more powerful than heroin, right? And the newest drug out there is 1,000 times more powerful than fentanyl, right? So, and yet people take it. They know they're going to die and they take it. So obviously, though, there's something about it that makes the idea of personal responsibility alone a moot point. People are jumping off bridges, it's the equivalent, and yet they're doing it. So the addictive part of it, I think, speaks to the issue of how it can harm you, and more programs, I think, should be put in place to address that issue. Because no one wants to kill themselves, yet they know if they take this drug, they're going to die. They do it anyway. It's amazing. So.
I have a chart that's from the chief medical examiner, and it's labeled Connecticut's unintentional drug overdose deaths. The data started being collected in 2012, and it goes up to 2017. And just the part that I want to focus on is the fentanyl in any death, which includes fentanyl plus cocaine, fentanyl and a prescription opioid, fentanyl and heroin, or fentanyl of any of the opioid analogs. The increase from 2012, where it actually lists no data, 2013, no data, 2014, no data, 2015, there's data, there's 2016 data, 2017 data. Those numbers are important. But what I will tell you is that the percentage of difference from 2015 to 2017, 992.3%. That should tell you all you need to know about the trajectory of fentanyl, and there's no way that people know what they're doing with this. Just like we didn't know 100 years ago about moonshine or all the alcohol issues that were coming out and how it harmed internal organs. It's an educational process, and we're behind the curve right now in terms of how fentanyl is affecting the illegal street drug trade.
I suspect, though, and just very quickly, that even if they do know, that lots of these people are so past the point of no return, it doesn't even matter to them.
In a lot of cases.
Yeah, to your point, we have a lot of educational programs out there, and it's exactly to your point. They know that there's a high risk, but the illness drives you to it.
Okay, other comments or questions?
Mine is just a comment. I just want to say that Narcan is not a solution. It's just a crutch. Once you are given Narcan, you have to go to the hospital because it only blocks the receptor of the opioid for a short period of time, and then you can't get the high back once you get the Narcan. So that's just my comment.
Thank you, Molly. Lots of hands up. Go ahead.
My question is to the woman who spoke on national policy. One, I'd like to know if the opioid epidemic falls within the purview of the CDC, and if so, have they come out and actually described this epidemic as a national emergency to date?
It's the CIA, the CDC and the NIH together work on these kinds of problems. There are people who work in both agencies who believe that that it is a national emergency. What I was talking about was the formal declaration of a national emergency, and we've had them in the past. We've had them when, not that long ago, I think it was the Asian flu. It was one of the flus where there was a medical national emergency. So it is possible to do that, and you can create the parameters of how long it will last, whether it needs to be reauthorized. There are definitely people who believe that that is the direction we should go in. But at this point, I think the administration, although there were some people in the administration who also believe that, there is not consensus that that's the direction we would take. And that's in part because you have some in the administration who still, I think, are more persuaded by the crime control model. In other words, that this is really not about a public health emergency, it's about crime instead. And so I think part of what thoughtful policymakers are trying to do on all sides of the spectrum is trying to allow people to see that you need to do both. That it's not either or. It's not arresting or giving medical treatment, it's both. But yes, there are people who take that position.
But they have not come out and officially described it as a national emergency as yet. Am I correct in saying that?
That is correct. There were people who really pushed for that, and there was a moment where President Trump seemed ready to do that. But for whatever reason, they pulled back. And again, there are lots of complicating factors. So you're asking a very important question.
One of which was that there was another national emergency declared.
Yes, instead, right. But and in fact, there were people who there were even just to be fair, there were Republicans who came out and initially there were some who said, particularly at the state level, right, the people who deal with it, who said the problem for us is not a wall. The problem for us is in fact this opioid crisis. So again, if you just Google, you'll see it will come up because there was a debate about that. Yeah.
I have three issues. One, I think a huge part of this, and I'm not looking to street drugs, I'm looking at the, my family was all involved in medical, pharmaceutical, and I think there's so many kickbacks to doctors and to pharmacists, and it doesn't even have to be money, but trips, you know, huge parties, whatever. You know, when you get into the big pharmaceutical companies, I think that's a huge part of the problem. Then you get into where the doctors are not, you know, are giving out these fentanyl and opioid, you know, other opioids combinations, not telling their patients that, oh, you broke your arm, I'm going to give you 30 days or 6 months of this opioid, you know, and you're addicted. And then why don't we have a pain center in Bristol? We have this huge problem. We have, you know, a wonderful, I guess, I forget what you call it, on Farmington Avenue, the methadone clinic. Why don't we have a pain treatment center in Bristol? And I know that there's one in West Hartford, and I know that there's one in Meriden, but, you know, there isn't a local one for the local issues. And the other thing about Congress is that I think there are drinkers and there's users. And you're not going to break through Congress until we get a hold of other issues too, like, you know, the effect that drinking has on people. You know, this has been a long time coming, and we all know that. Yet, there's overuse of alcohol, and along with it go drugs too. So those are my comments. But I'm very grateful for your handling.
The issue of pain clinics.
There actually was one in Bristol, and it proved to be part of the problem, and that doctor was encouraged to leave Bristol. You know, it's one of those things where part of what we're doing on the task force is identifying alternative methods of pain management. We have seen great frustration with some of our medical community, including our chiropractors, who will guarantee that they can help people come back from injuries, from, you know, the knee surgeries or the athletic injury, and they rehab these patients only for, you know, if there's a re-injury, instead of going back into this alternative method of treatment, they're put back on pain pills and the process starts again. We've seen that in our workers' comp system. We've seen it with people coming out of treatment and yet returning to their home, to their neighborhood, to their circle of friends who unfortunately don't do the right thing and are not supportive. So it's a multi-layered issue, and people need to be really strong in order to come out of recovery, stay in the same environment, and maintain recovery. Part of that goes back to what I was talking about before in terms of the stigma piece. Sometimes people don't ask for help. It gets too late. You have a situation where the chief's department is involved, or you have, again, and I keep harping on it, Bristol family, great family, involved in the community. 2 sons. One went the route of illegal street drugs and was incarcerated. The second son dabbled in all kinds of things and had a sports injury in high school. Ended up becoming addicted to pain pills. His parents sent him to treatment 3 times. And the 3rd time he came home, and his friends came over to welcome him home, and his mother found him dead 6 hours later. That's the reality of what's happening. It's a multi-pronged approach, and we can't help people if we continue to stigmatize it. Language matters, and that's one of the issues. That's one of our handouts. Are you an addict? Are you a user? Are you a junkie? Or are you a person with an opioid use disorder, a person with opioid addiction? Or are you a patient? Are you an addicted baby? Or are you a baby born with neonatal abstinence syndrome? Do you have a habit, or do you have an addiction? Did you have a clean or dirty urine test? Or do you have a negative or positive urine drug test? Did you relapse, or did you return to use? Are you being clean as opposed to being dirty? Think about that in terms of how you characterize someone. Or are you in remission and recovery? These terms matter, and you think about it in terms of your brother, your parents, your uncles, your cousins, or the people that you grew up with in your neighborhood, and how you label them has a large value in how they value themselves and the next step they take, which is hopefully into recovery, or the next step they take, which might mean the last step they take.
Mr. Howard?
Yeah, and I would just add one point to your comments, because I think what you said is true. If you look at the 1999 to 2003, and you look at that kind of West Virginia, Kentucky, that hotspot, there's one other point that, again, this is such a complicated problem, why it's called a wicked problem, right? And what happened is there was an issue with drug distribution, and only the federal government can control the distribution networks. And what was happening is that in a town of 300 people, 3 million pills, okay? And so part of what we need to understand if we want to know about the federal response is that there needs to be much more control, and they actually have changed it. It's one of the things that they changed. So they've changed that distribution. But what happened is there was a point where there was very good control of distribution. Quite frankly, the drug industries influenced Congress. They loosened up, and as a result of that loosening up, they were able to distribute these drugs. Now again, it's been changed somewhat, but that's another point that's so important, why we need collaboration at all levels, because the states can't do that. The states don't control the distribution networks, the trucks, where they go and where they deliver.
I just want you all to imagine, just for a second, if that bottom left map was a reflection of, let's say, an Ebola outbreak and the number of deaths. Just for a second, how would we be treating that? It would be national emergency and then some. So, okay, other questions? We have time for a few more. Yes.
Yeah, so one comment on kind of the policy, both nationally and local, here in the state. I'm a research assistant with Connecticut Children's Medical Center, and my current project is with the Department of Public Health on the Enhanced State Opioid Overdose Surveillance Grant, which, as of now, the CDC has 31 states signed on, Connecticut being one of them. And what we're collecting on all of that is the full picture of that particular opioid death in a very broad, multi-dimensional direction, where we're looking at a person's medical history. We're looking at if there was any sort of illicit drugs involved with it. The prescription monitoring program here in Connecticut is another factor that we put into that. And we take all that information, also coming from the Chief Medical Examiner's office, and putting it into the National Violent Death Reporting System. And the one particular module within that is the SUDORS module, which is looking at opioids specifically, the state unintentional drug overdose reporting system. So I think in speaking on the issue of getting this information to the people that need to get it within our political system, it is out there. It's just a matter of them actually taking it on and trying to see it at face value, and putting the time in to actually know the facts and know the issues that are going on. So, yeah. Thank you.
This young lady has wanted to speak for a long time. I know how that feels.
They're going to hear me regardless, whether it's in this room or later today. First off, thank you guys for coming. That's pretty awesome. I'm actually the sister of a former heroin user, and it tears families apart. I was away serving in the Marine Corps when my sister was at home getting in trouble. So you wonder, how can two apples fall so far from the tree? I came home and she was in prison because of her use, because of some other things that were surrounding that. And now some of the issues we come across now that she has been clean, for lack of a better term, finding jobs, finding, proper insurance, finding all these different things to make her a better contributing member to society. What is being done, or what can be done from our side, to be able to keep them as contributing members to society and not to go back into that cycle. I recently sat in on an open committee in Harvard for House Bill 6921, which deals with sealing criminal records. Is there anything being done locally besides that that could perhaps help those who have used in the past so they can get beyond that and not go into that reoccurring cycle. That's one. And for two, if you guys have already established this task force in Bristol, is there any other way forward, if you will, for the state of Connecticut? Are you guys talking with other country or other cities? Is it that model that's being used here that seems so awesome going to be used elsewhere?
That's a
And
great
is there
question.
talks of that? And if not, what do we have to do to help support you guys in that?
Right, right.
Okay, so that's like 3 different issues. The first one, the workforce issue is huge, and congratulations to your sister for being in recovery and staying in recovery. I was in Hartford for a legislative public hearing a couple of days ago on a bill for our emergency responders. At that same public hearing in labor and public employees, yeah, the decriminalization bill.
Yes.
It's a huge factor in terms of, we have all these jobs in the workforce that we can't fill, and now we have all these people who have fulfilled their obligation to the penal system and are now on a better path, and we're still punishing them. So if you've done the time and you come out, you should be able to continue your life. That's not necessarily the case, and it goes back to what I was talking about before, the stigma. So one of the things that we've been doing is discovering different resources. And again, I personally believe that the state of Connecticut, through the whole alphabet of DEMAS and Public Health, DPH, Department of Consumer Protection, where the PDMP is housed, everybody has really come together. And I know it's not popular to say this, but honestly, a lot of the credit goes to Governor Malloy, who in 2013 said, wait a minute, we have a problem here. Shortened days of prescriptions for some of the opioid narcotics from 7 to 5. You're now allowed to put a piece of paper in your own file that says, I don't want opioids prescribed to me. Electronic prescription filing has eliminated that paper piece that is so easy for doctor shopping, as well as really kind of fraud in terms of getting prescriptions that don't belong to you. How many of you have heard of people stealing the prescription pads and then going pharmacy to pharmacy? That's real. Electronic prescribing is eliminating all that. And all that emanated here in Connecticut before this was on a lot of people's radars. The next piece that our task force is looking at is establishing Bristol as a recovery-friendly community. And there's some people who don't think we should do that because they think it doesn't look good. Well, it also doesn't look good when you have people who can't get back and be productive members of community because they can't land a job because they're being discriminated against because they spent time in prison for some level of offense. So the recovery-friendly community is a checklist, and part of it is for municipal buy-in, for community attitudes, community resource, but it talks about, do businesses support the hiring? Will we as a community support formerly incarcerated individuals? And are we open for job and volunteer opportunities to people? The other quality of life piece is, how do you stay on that straight and narrow path? The other safety net piece that we try to do is design a quality type community where you're thinking about something and you just saw somebody that you know might have something that you might want. What can you do instead? So we're pushing the whole alternative therapies. Go to your chiropractor, go take a walk in one of our parks. We have recovery clubs, we have these support groups. And here's the interesting thing, going back to stigma. We've worked with Wheeler Clinic and Bristol Hospital to design various types of, at all days and times, of support groups for families and for people. We have a Suboxone clinic now that Wheeler Clinic is sponsoring in downtown Bristol. We have the methadone clinic, the Root Center. And yet we have all of these opportunities for group counseling, for recovery, for coming together, and very few people go to them because they don't want to have their neighbor Mary see them walking into that counseling center saying, oh, why were you at Bristol Hospital Counseling Center the other day? Oh, I saw you walking into Wheeler Clinic. Or worse yet, you're there and you see somebody you know. And that is absolutely the wrong attitude. So a recovery-friendly community is something that Bristol's looking at to kind of, again, use it to break down those barriers. We haven't endorsed it yet, but it's the next thing that's on the task force's agenda. And working with employers to help people like your sister is actually on it, and we're working with the Chamber of Commerce with that as well.
I know there are a few more questions. We're almost running out of time, and the next students have to go to their next class, but maybe 1 or 2 more questions. Is it okay if you stay a couple more?
Sure.
Robin, I know you have.
I don't know. I just think it's important that we not ignore the role that insurance companies play in this. It's much easier for them to pay for a pill than it is for them to pay for chiropractic or for physical therapy, and I think they need to be held accountable as well.
Okay, this lady's had a question for a very long time.
Oh.
I am looking at it. Because I'm short.
Okay, my question is based on this opioid use here in our country. Like, most of us that doesn't even know the science, major science, how can you be able to know if somebody is on that overdose, addiction, or abuse of the drug? Because I know that domestic violence is tied into drug addict or whatever. So what are the basic, factors or signs for you to suspect that somebody is on that?
Well, I mean, there's so many scientific studies that talk about people's normally addictive type personalities, impulse. There's genetics and hereditary. There's environmental factors, homelessness, mental health, domestic abuse, parental abuse, abandonment. I mean, you name it. And there's any factor that can put somebody on the path to addiction, keep them on the path to addiction, and prevent them from getting into recovery. There are some people who the deck is loaded against them. And again, that creates that social safety net and the role of government. And I totally empathize with people, and we hear it all the time. You Narcan the same person 3 times a week. Yep, yes we do. But that person is somebody's sister, it's somebody's cousin, it's somebody's child. And if that last dose is what gets that person out of the cycle, then we've done our jobs.
So, you were looking like for signs of some use, meaning like, one of the big things you can look at as people is their altered being. Big thing is in the eyes. So if you look in people's eyes, you'll see a lot of responses in the pupils. A lot of people that are on different stimulants or opiates, you'll see their eyes either dilate or constrict. So you can tell a lot by a person's status if you see them being lethargic. Those kind of signs and symptoms are cool, there's something going on. Look around for paraphernalia, any vehicle type that to use these type of drugs. But really it's about that state of being, if they're in a confused or state of delirium. Those are signs that there's something going on. It may not necessarily be a drug, but that's a sign. Really look at the eyes. You'll see those pupils either constricted or dilated at the wrong times, and that's a sign for you to look at.
I think one last comment, and I've seen your hand up for a while.
Hi. So I just have a question. As individuals, how can we help these people, and how can we raise awareness in our environment so to change how other people see drug addicts or people that are in this situation?
There's a few ways that you can have a voice, and one is even just every once in a while cruising your own state legislators' websites, seeing what they're supporting, seeing the bills that have been introduced, letting them know that you think that this is important and that state resources should go to this. There's a lot of ridiculous bills that are introduced every year. And if I sit through one more hearing about changing the state bird, I'm probably going to lose my mind. But that's literally what happens at the Capitol. And, you think about in terms of the priorities and what needs to be done and our fiscal situation, it's really important that the state legislature hears from people like you so that they know that the next time they're sitting in a hearing, maybe they start paying attention. And you really just need to be supportive of people. If you suspect that someone's having a life situation or is in any type of path to addiction, you need to be their friend and get them to a place to really arrest the situation before it becomes full blown. And that's hard. Sometimes it's a very resistant type of relationship, but there's resources available, and I'm going to leave some of these. These resources are available in other towns as well, and I don't think I really sufficiently answered the question that was asked before. Bristol's the big fish in the small pond, and I have reached out to the mayors and first selectmen that are in the towns that surround Bristol, and we are willing and able to work with them because they don't have the resources that we do. So they are slowly thinking about replicating, but more importantly, collaborating with us. Bristol Hospital is the hospital for many of these communities. We have people crossing lines. We have people from Plymouth and Woolkit and Farmington and Plainville coming into Bristol. We have Bristol people going into those communities. It's definitely a conversation amongst a community, but a lot of these resources can be found, police departments in every town. You know, it's just a matter of letting someone know that you care and getting them the help that they need as soon as they can.
In my American government course this morning, we made the point that as individuals, we're not nearly as powerful as we are collectively. And I would urge all of you to embrace the cause and get together and organize, because that's the way change is affected in American society. Many historical examples of that. So group efforts are always much more effective than as an individual trying to appeal to a government official. So anyway, I think because there are more questions, this kind of begs for a third round of an opioid discussion. I know James wanted to discuss the decriminalization part of it, which we haven't really broached today. Before you go, could you please thank the panelists for their brilliant